So next video is 15, and it's a Synchronous AAA and colonic tumor. It's very important talk. 78-year-old male presents with 2 month history of constipation and 5 days abdominal pain. His abdomen is mildly tender and distended, but no peritoneal signs. Abdominal X-ray showed dilated loop, small and large bowel. Your effort to resident place an NG tube for decompression, starts intravenous fluid resuscitation, and arranges for a CT scan. He has an obstructing sigmoid colon mass, less than 2 centimeter left liver lobe lesions, suspicious for metastatic lesions, and 7 centimeter infrarenal abdominal aortic aneurysm without evidence of rupture. So how will you manage this acutely? So first of all, we have to admit the patient, give him oxygen, IV fluids, analgesia, antibiotics, and send all his baseline blood, including FPC, CRP, UNEs, LFTs, coagulative profile, send group and cross match, and examine his lower limbs, because all the patients who have aneurysm, they might have has popliteal aneurysms, and do ECG and cardiac enzymes. He remains stable and becomes less distended with improvement in the abdominal tenderness. How will you counsel the patient, and what operation would you give him if you think he needs one? So this patient has multiple indications for surgery that include colon cancer and aneurysm. The more urgent indication is the obstructing sigmoid cancer. However, in the presence of a large AAA, it will be beneficial to manage this with a multidisciplinary team approach. If patient has a complete bowel obstruction with peritonitis, then he should undergo sigmoidocolectomy and Hartmann's endoscopy for decompression. His definitive oncological resection should be dealt with a later date, along with his metastatic liver lesions and AAA. But in the absence of complete bowel obstruction and improving symptoms, treatment of his AAA should be staged earlier, because the endovascular EVAR is preferred for few reasons. Address the risk of rupture periaperitoneally. If we are doing colonic surgery, this aneurysm can rupture. It avoids the laparotomy and potentially laparotomy for subsequent colon or liver resection. The inferior mesenteric artery is usually sacrificed in an EVAR, and this may affect the extent of colonic resection, which is also dependent on the availability of the cut colonic edges. EVAR following colonic resection can obliterate the AMA and potentially lead to an osmotic breakdown or ischemic strictures. There is some evidence of increased risk of AAA rupture if left untreated after colonic resection and while receiving the chemotherapy, hence the push for early EVAR. However, it is also debatable if EVAR should be offered if the life expectancy of the patient is less than 2 years. In selected patients with stage 4 colon cancer, such as this, successful colectomy and resection of his metastatic lesion can have a survival advantage of 36 months or greater. Your vascular colleagues performed an EVAR successfully on the evening of the post-operative day 1. He passes bloody mucus per rectum and complains of diffuse abdominal pain with distension. He is tachycardic to 100 beats per minute. His blood normal had been oliguric in the previous 2 hours. What would you like to do with these findings? So concern is colonic ischemia and necrosis post aneurysm abdominal repair, which has mortality rate of more than 80%. FBC, renal panel, arterial blood gas, and serum lactate. So flexible sigmoidoscopy, acknowledging that you may not visualize proximal to the obstructing mass. Evidence of colorectal ischemic necrosis mandates a return trip to operating room for colectomy and likely end colostomy. So it's quite a huge number. If someone have over post AAA repair has necrosis ischemia, mortality rate is 80%. What are your thoughts on concurrent colectomy with anastomosis, liver resection, and open AAA repair, since the patient is going to have a laparotomy anyway? So here, infection with the aortic graft and the risk of bleeding, because for the vascular surgeon they will use the anticoagulants, will lead towards the bleeding from the colectomy and liver resection. What if presentation was different? For example, this patient presents with a contained rupture of an inferior aneurysm, mildly hypertensive, and you are in the mindset of an open repair. You notice that the entire large bowel is distended between 6 and 8 centimeter diameter, and you identified a large obstructing sigmoid colon mass. What would you do for this patient? Priority of the treatment is control of the bleeding and AAA reconstruction. Complete the vascular repair, close the ASA over the thoracic graft, aortic graft, and close the peritoneum. Mobilize the descending colon and polar loop to externalize in the left colon lower quadrant, close the abdomen, and complete the operation with the loop colostomy. This minimizes the risk of aortic graft contamination infection. Address the colon cancer at a later stage if patient survives to recover. Thank you.